ECMO or Impella, which goes first in acute heart failure? Veno-arterial extracorporeal membrane oxygenation and the Impella pump constitute the first line among mechanical circulatory support devices in our daily practice. However, these two devices present some specific features. ECMO is a centrifugal pump which provides a blood flow at an almost physiological rate between 4 and 6 liters per minute, and it also ensures blood oxygenation and carbon dioxide removal. And it supports both the left and the right ventricle. However, cannulation requires a large bore arterial and venous access, and the device operation is challenging and requiring some experience. Nevertheless, the biggest issue is the retrograde flow within the aorta, because the ECMO takes the blood from the right atrium and the vena cava and pumps it into the aorta in a retrograde direction. As a consequence, the afterload significantly increases. Nevertheless, the ECMO enables us to perform such operations which haven't been possible before, like this complex PCI among a very old lady. The main indication for veno-arterial ECMO is cardiogenic shock, but it is also used in cardiac arrest, post-cardiotomy shock, in high-risk coronary interventions, and as a management of complications of invasive procedures, as well as a short-term bridge to transplantation or LVAD. As I mentioned before, due to the retrograde pumping, the afterload significantly increases during the ECMO therapy. And the higher ECMO flow, the higher left ventricular loading, which is reflected by the increase in the end diastolic pressure and volume, and the decrease in a stroke volume. This may be a big problem if the patient's left ventricle is very weak, like in this young man with fulminant myocarditis, in whom during the ECMO therapy, his very weak left ventricle was not able to open the aortic valve, and the patient was on constant pulmonary edema. In such cases, we should employ one of the methods of the left ventricular unloading. The most commonly used method is intra-aortic balloon pumping. However, this method is often ineffective, and it was also ineffective in our young patient, and only after the replacement of the balloon pump to the Impella pump, the patient was able to recover from the pulmonary edema. Indeed, the Impella pump is the most effective method of the left ventricular unloading. The third method is a balloon septostomy, which enables shunting the blood from the left to the right atrium. And this is not only a spontaneous flow from the left to the right atrium, because this flow is enhanced by the ECMO. The ECMO takes the blood from the right atrium and it accelerates the flow from the left to the right atrium, and it enhances the left ventricular unloading. The balloon septostomy is usually employed when the Impella pump cannot be implanted, like in this patient with a mechanical aortic valve. And please note that in this patient, balloon pump was ineffective to unload the left ventricle, and the balloon septostomy had to be performed. As regards the Impella, this is the microaxial pump, and there are several types of Impella. The most commonly used type is the Impella CP, which generates a moderate blood flow between 3 and 4 liters per minute, and it exclusively supports the left ventricle. If we want to support the right ventricle, we have to implant additional Impella dedicated for the right heart, which is called RP. The overall device operation is easy and very friendly, but the most important advantage of the Impella pump is the very effective left ventricular unloading. The cannulation requires only a single access with 14 French sheath, and this 14 French sheath may also be used to insert a guiding catheter if we have limited access to large arteries, and which is often very crucial during the procedures in patients suffering from the cardiogenic shock. But this guiding catheter cannot be simply inserted through the hemostasis valve, because this would cause big bleeding. We must first puncture the hemostasis valve and insert a 6 or 7 French sheath, and through the sheath we may insert a guiding catheter. In general, the Impella is very friendly when we have limited access to the large arteries, and even if we don't have an access to femoral arteries, still Impella may be implanted through the subclavian region. And this procedure may be done fully percutaneously without surgical cutting, and also Impella may be removed percutaneously, and the access site may be closed with probe glides without employing surgical method, and the final hemostatic effect is usually very good. Another advantage for the Impella pump is the protection of kidney function. It was shown that in patients who underwent high-risk PCI, those who were supported with the Impella pump, they significantly less frequently experienced acute kidney injury. And also in our material, patients undergoing high-risk PCI who were supported by the Impella, only few of them experienced very slight increase in the creatinine level, despite the fact that the risk of acute kidney injury according to the Mehan risk score was almost 40%, and the contrast amount used in these procedures was incredibly high. On average, it was more than 300 milliliters. But let's compare Impella versus VA ECMO head to head. In an animal model of cardiogenic shock, both devices were able to increase contractility of the left ventricle, but only Impella was able to reduce end-diastolic pressure and volume and to increase stroke volume. As regards ECMO, it was associated with the overall increase in the workload of the left ventricle. However, ECMO was more effective in improving organ perfusion. In this term, Impella CP required norepinephrine to maintain the mean arterial pressure over 40 millimeters of mercury. So the question appears, what is more crucial, improving end organ perfusion or ventricular unloading in cardiogenic shock? In a retrospective study, patients treated with Impella or ECMO for cardiogenic shock after myocardial infarction. However, they did not differ in 30-day mortality. So there was no difference in terms of survival between these two devices. But what about simultaneous usage of these two devices? Also, in a retrospective study, very recent study, VA ECMO together with the Impella reduced mortality comparing to VA ECMO alone. And it was observed in both unmatched and in matched groups. And what is even more important, the only early left ventricular unloading with the Impella pump, that is within 2 hours after the initiation of the ECMO therapy, it was able to improve prognosis. If the Impella was implanted later than 2 hours after the beginning of the ECMO therapy, there was no benefit in terms of survival, in terms of prognosis. But let's see what is the impact of the left ventricular unloading on coronary flow. In one of our patients, we recorded FFR during the Impella therapy. Actually, it was PD to PA ratio without hyperemia, so let's call it spontaneous FFR. And this spontaneous FFR during the Impella therapy was actually kept at the constant level. We gradually decreased the Impella flow, but it was actually this decrease had no effect on the FFR. Even at the minimal flow, that is P1, the FFR was kept at a quite high level. But when we switched off the Impella, there was a dramatic drop in the FFR. When we switched on the Impella again, the FFR increased again. And you can see what is the impact of the Impella therapy on the coronary flow. We don't know whether this is the effect of the mechanical left ventricle unloading, or this is the effect of the flow generated by the Impella. However, we may observe such an effect within the coronary arteries. And the new concept in the management of STEMI is to unload the left ventricle before reperfusion. In this pilot, very small study, a 30-minute delay in reperfusion while unloading the left ventricle had no effect on the infarct size, on the left ventricle ejection fraction, and also on mortality. So even if we delay reperfusion by we unload the left ventricle, the muscle is safe. Of course, you would expect some benefit, not only a neutral results, but for more encouraging results, we have to wait until the large clinical trials will be carried out. To conclude, the Impella is a powerful method for left ventricular unloading, whereas ECMO is more effective in organ perfusion. Due to the selection bias, the retrospective studies are inconclusive in terms of superiority of one method over another. However, the implantation simplicity and the reduction of cardiac oxygen demand prompt Impella to be a method of the first choice in cardiogenic shock, at least in my opinion. Thank you for your attention.